Hello everyone. I hope you all are doing fine. And so I will start with the today 5 pages that we need to cover. All right, so antibiotic hypersensitivity. So, hypersensitivity is basically the allergic reaction that we need to study because, as it is also mentioned in the previous pages, that whenever you will prescribe any antibiotic to the patient, you should make sure that he is not allergic to them because it is very commonly seen the patients to be allergic to antibiotic and mainly the penicillins, which are the main major group of antibiotic that we usually prescribe for any infection. So you always need to make sure. I was thinking maybe I would not read line to line because it can get more boring for you. I'll just explain the important points so that can stick into your mind, and you know, I don't want the class to be more boring and all the stuff. Maybe let's try with this method and let's see how we go. And if you have any suggestions for me, you can always message me or put in comment box. I would be happy to try your method. All right, so it is common for patients to try to report a history of allergy because allergic reaction to penicillin is very common problem, and which we as a clinician we always do experience these type of patients, right? So in those conditions, what we can do and what's the actual scenario, that's what they will talk here. If the antimicrobial is administered to an allergic patient, then the severe reaction can occur. However, it is known that many patients who reports an allergy tolerate the drug if it is administered again. A patient's history of antimicrobial allergy often raise, whenever you will ask a patient, are you allergic to any medication or penicillin, they would say yes. If you would ask him like what has happened actually, so they would generally describe it as there was a rash with any vague feature while I was younger. So this is the common feature that they explain you, but it could be a drug viral interaction also that can lead to these rashes. So, in fact, few childhood reactions are responsible in adulthood, and over 90% of reported penicillin allergy can be excluded. So, there are certain tests which help us in excluding the allergy. Like we can make sure if the patient is actually allergic to penicillin or is it any other thing like drug viral interaction or what's actually the reason. These tests are known as skin testing or oral provocation. But these tests are done under specialist or in the hospital. You should not be doing any of these. Okay, so careful assessment and confirmation of antibiotic hypersensitivity ensures that patients with serious infections are not unnecessarily denied the most effective treatment or untreated. So, here they want to explain that it is very important to assess if the patient actually have the allergy to that particular medicine. For example, if I got any infection, and for that infection, the best antibiotic is amoxicillin. But in my mind, I'm thinking, or from the previous experience, I'm telling my doctor, no doctor, you cannot give me amoxicillin, as while I was younger, I got a rash with that. Penicillin and I'm allergic to it, but in the real sense, I am not. It's just that I'm relating it to any event in the previous. So it is very important to get it tested and then get the effective treatment. Accurate and detailed information about antimicrobial hypersensitivity must be documented in the patient's medical record. And whatever the information you have about the allergy, you should write it in the patient's medical record. In Australia, it is very important to do your notes, and in your notes, you should write each and every word. Your notes would help you in if there is any condition where you can get in danger, or there would be any patient wants to sue you, your notes are the only thing that can help you with actually what has happened at that point of time. If a reported allergy is subsequently excluded, then update the medical record, and to avoid relabeling, include information about how the allergy has been excluded. Advise patient to wear if the patient has like the patient comes to you, he said that he is allergic, you advised him the tests, which are the skin testing or the oral provocation. After the test it is confirmed that the patient is allergic, then you advise the patient to wear a medical alert bracelet or a necklace. Following a confirmed if he has severe hypersensitivity reaction, for example, which include drug rash with eosinophilia and systemic symptoms, Steven Johnson syndrome, toxic epidermal necrolysis, or after allergy is confirming on testing. Okay, so for information on anaphylaxis, we will read in the following pages in the emergency chapter. But yeah, so it is very important if the patient has confirmed allergy, you can advise him to wear the alert bracelet or necklace that will help in identifying. Common misconception that we have about the allergies are, first of all, that the allergy is lifelong. We usually think if we are allergic to something in the when we were younger, we would still be allergic to that thing, but it is not true. They say that antibiotic allergy is likely to wane over time, and many people who report an allergic reaction in childhood are able to tolerate the drug as an adult. Other misconception is all childhood rashes associated with antibiotics allergies. Okay, but they say that mostly these rashes occur because of any viral infection or a drug and viral interaction rather than any drug allergy. Okay, and the third misconception is that all the documented antimicrobial allergies are always true allergies. In an Australian review of antibiotic prescribing, up to 20% of documented allergies were pharmacologically predictable non-immune based adverse reaction like GIT intolerance. So it is not an allergy, it is pharmacologically predictable, because some drugs can make you go like nausea, and the antibiotics can make your body and can leads to diarrhea. So this does not mean that you are allergic to antibiotic. Okay, and the misconception is cephalosporin cross reactivity in patients allergic to penicillin is around 10%. So previously it was thought that if the patient is allergic to penicillin, then there is 10% chance that he would also be allergic to cephalosporin. But now, according to reviews, it has been found that it is only 1 to 2% now. Okay, then the types of antimicrobial hypersensitivity. They have divided it into two parts, type A and type B. Type A, they have written like the pharmacological predictable reactions. For example, any gastrointestinal intolerance. And type B means unpredictable. You don't know. It can happen to anybody, anyone, at any time. Okay, so type A are the predictable ones, and type B, you don't know about them. The most common types of immune mediated reactions are immediate, IgE mediated, and type delayed. So, antibiotic hypersensitivity type A means that you know that you will inform the patient if you will take this drug. Like, for example, if you will take the antibiotic, you can get the diarrhea, Okay, and there might be some nausea or any other symptoms, but the type B reaction, you don't know, it can happen to anyone. Like the either the IgE mediated, it means the type 1 reaction, or the type 4, which is the delayed T cell mediated allergic reaction. Immediate or acute reactions that do not involve an AIGE-mediated mechanism can also occur. For example, this was previously an MCQ that used to come, which was about red man syndrome. So when the patient takes vancomycin infusion, so they can get allergic reaction which is not IgE mediated. So they named it as a red man syndrome. These are usually caused by direct mast cell granulation. You know, right? These IgE mediated or T cell mediated, these reactions, they do have certain mechanism how they happen, like certain enzymes released and they act on other things, and that's how this reaction happens. But this vancomycin infusion related syndrome, this does not involve this mechanism. This just directly act on the mast cells that releases the histamines and may be ameliorated by prophylactic antihistamines and slowing the infusion rate. Yeah. Okay, then here we can study in detail about the IgE mediated hypersensitivity reactions. Is characterized by a reaction ranging, like it could be a mild urticaria or could be an immediate rash to more severe reaction including extensive urticaria, compromised airway, angioedema, hypotension, collapse, or anaphylaxis. Okay, so this IgE has basically three stages. Okay, so first stage is only the urticaria. Urticaria means there would be a redness and itchiness. Second stage is angioedema, when there is fluid which is getting entrapped either below our skin layer or towards any hypotension or any angioedema. Then the third stage is collapse or anaphylaxis. The reaction occurs soon after the because it is immediate type, so it will occur soon after the a drug is taken, typically within minutes to 2 hours. That's the reason it is immediate. So the reaction could occur within minutes to up till 2 hours of time. Anaphylaxis is more likely with parental rather than the oral administration. Why? Because with the parental route, we are infusing more amount of antibiotic, right? For penicillin, anaphylaxis occurs at an estimated rate. They have estimated that 1 to 4 cases per 10,000 courses can have a chance of happening of anaphylaxis. A clear history of an IgE mediated reaction means that drugs and sometimes related drugs should not be administered again unless if the patient has got any anaphylaxis reaction as a past experience. You should not be repeating that in medication to him, or not administered again unless appropriate precautions can be taken. Like for example, like the testing that we talked before, like the oral provocation, in that test method, they basically give the drug to the patient and they observe him under the condition, like how does his body responds to that drug now. But if there is any emergency, they do have certain procedure that they can handle that, but it is done with the specialist advice only. You would not be doing any of these tests. Not all immediate hypersensitivity reactions are severe. So as we understood here, so they could be mild urticaria as well, like the only the redness that can go away on its own. Then the delayed immune mediated hypersensitivity reaction, they are basically the T cell mediated. and produce a range of syndrome commonly characterized. Okay, so you just need to understand that this delayed immune mediated reaction have a certain pattern. Either it could be a dress or Sjogren syndrome or any of these. They do have a rash in them, and these reaction typically occurs after more than one dose of drug. Like they do have a systemic feature, like for example fever and eosinophilia, and a type of rash, like for example here desquamative dermatitis, or organ involvement like liver or kidney dysfunction. Same here, like the fulminant epidermal skin and epithelial mucosal loss similar to burn injury. And so I will tell you like any particular things about these reactions, but they do not generally ask any questions in detail about these reactions. But it just for your knowledge, you can get an idea. Okay, so delayed hypersensitivity reactions are far more common than immediate reactions. The majority are not severe. Okay, and a most important thing is here, like, however, delayed immune mediated hypersensitivity reaction can occur more rapidly on re-challenge, like within 6 hours. If the patient has taken any medication now, and if he will repeat the dose after 6 hours, or generally we ask the patient to repeat the dose, like take it 6 hourly or take it 8 hourly. So on the re-challenge, the chances of happening of this reaction is more. Okay, so delayed hypersensitivity reactions are far more common than immediate reactions. They often occur in patients with a viral infection and can be due to the infection or a drug virus interaction. Consequently, such reactions may not be reproducible upon a supervised challenge when the patient is well. In particular, a mild maculopapular rash caused by a penicillin, especially amoxicillin or ampicillin, is not strongly predictive of a future reaction, and many patient tolerates the drug if it is administered at a later time. Okay, so delayed severe reactions are uncommon, but they are serious. If they does happen, it is very serious thing. They include severe cutaneous adverse reaction. A group of T cell mediated hypersensitivity is with cutaneous plus internal organ or mucous membrane involvement. Okay, so they do have a certain pattern to follow, like there would be a rash or there would be skin involvement plus internal organ or mucous membrane involvement. Like in dress, there would be, this is the systemic, right? So fever, eosinophilia, and then this is the skin involvement, desquamative dermatitis, and the organ involvement is the kidney and the liver. For the Steven Johnson syndrome, you can just remember it like that, that the injury would be so severe that it would look like that the patient's skin is just, it would be just like a burn injury. The skin would be just fulminant, and it's so bad to see these. You can look on the images on Google, you can search for it and you'll get an idea. For this reaction, acute generalized xanthomatous pustulosis, you can remember it like that. Although these all are delayed reactions, but this is a quick onset following a drug administration. Like this can occur quickly as compared to others. So you can just try to remember each and everything, like through one line or something which is different in these ones, because they all would have the systemic involvement, then organ involvement, and the skin involvement. Okay, so the acute interstitial nephritis, it is basically, it occurs with the penicillin mainly, and it causes kidney dysfunction and eosinophilia, fever, and xanthomatous rash. Okay, so for the AIN, you can remember it happens with the penicillin. And the serum sickness, it is characterized by vasculitis or articular rash, arthralgia, arthritis, fever, hypocomplementemia, and sometimes proteinuria. And this serum sickness happens with the cefaclor, then by cefaclor, then other cephalosporins, and also by sulfonamide. So serum sickness happens with the cefaclor and sulfonamides. Uh, AIN occurs with the penicillins. AJEP has quick onset. Steven Johnson has like the burn injury, and dress has the like the fever and the eosinophilia and the desquamative dermatitis and drug induced liver disease. A delayed severe hypersensitivity reaction is a contraindication to further drug exposure, including desensitization, because this can be fatal. So you should not be repeating that drug to the patient, which you know that patient is already allergic to it. Further drug exposure, including desensitization, is contraindicated following a delayed severe reaction. So, how would you diagnose that if the patient is allergic or not? Firstly, you will take the history and then you will do the tests. Okay, so in the history, which are the important things that you need to ask from the patient? The clinical history is critically important in the diagnosis of antimicrobial hypersensitivity. For example, if hypersensitivity is reported, ask about the nature and the severity of the reaction. Like you need to ask what actually happened at that time. Like they have provided these questions. How would you do the antibiotic allergy assessment? First of all, you need to ask them what was the severity and the type of reaction. You can ask by asking these questions like, do you remember the details of the reaction, or how was the reaction managed? Did it require treatment or hospitalization? For the timing, how can you ask like, how long after taking the antibiotic did the reaction occur? Here you are trying to understand, was it immediate one or was it delayed one? Then how many years ago did the reaction occur? Then antibiotic use since reaction. Did you tried any antibiotic, or was there any other problem with any other antibiotics? Okay, so you need to ask this question here. Common pharmacologically predictable antimicrobial adverse reaction, like we have read previously, like which are the nausea, vomiting, diarrhea, and the neurological, for example, headaches, dizziness, and skin effects like pruritus without rash, fever. So these things we can expect. These can happen, okay, and in many cases, these reactions do not justify avoiding the antimicrobial in future. If the patient only had these type of rashes, you can safely prescribe him the antibiotics. It's not an issue. But a family history of antimicrobial allergy does not justify. And if the patient says, oh no, my mom has allergy to this antibiotic, then also it does not preclude him. You can safely prescribe him the antibiotic. All right. So, if you suspect that this patient might originally or might actually be allergic to the penicillin or the drug, you can offer him and ask him to get some tests done. Okay, so here they have written when to do allergic testing. The role of allergic, because if you will send the patient for the test, you need to understand this would be an additional cost to the patient. Okay, so whenever you will prescribe any medication to the patient, whenever you ask him to get any test done, you need to keep in mind what is the benefit and what is the risk of doing this, because this would be an additional cost to him, and is this really important, or we can work it without doing it? Okay, so you need to wait. So they have mentioned here when to do the allergic testing. The role of allergy testing is largely limited to assessing patients with the history of if you are too sure, like the patient is giving you particular history of immune mediated, which is mainly the rash and either the anaphylaxis or any delayed reaction type, seek expert advice. Then you need to take expert advice if considering allergy testing. Allergy testing is most accurate when performed as early as possible after the patient has recovered from the acute reaction, usually at least 6 weeks after the reaction. For example, you have prescribed any patient like the antibiotic and he didn't know that he has any allergy, but after the reaction, after taking the antibiotic, he got all those symptoms of the allergy, and you need to make sure. Then what is the best time to offer him for the allergy testing is usually at least 6 weeks after the reaction. Why? Because results may become negative over time. An allergy test can be negative even in patients who have true allergy. A negative test results in the presence of a strong history can be a false negative result and requires specialist interpretation. Okay, so when you are too sure, like this patient has got, he has the true allergy, but the result shows that it is not a true allergy. Okay, so then you need to take specialist advice on that. Okay, so they have explained about the tests. First of all, is the skin testing. In, that would include either the skin prick, it means they will prick inside the skin, or can do the intradermal testing with immediate reading. It is this the standard method to used in specialized centers to test for immediate or IgE mediated hypersensitivity. These tests have good sensitivity and specificity if performed soon after the reaction, especially for phenoxymethylpenicillin, benzyl penicillin, amoxicillin, and ampicillin. So, for these four drugs, they mentioned that if you are suspecting any immediate hypersensitivity, then this test would give us the good idea or the give a good result. Intradermal tests have better diagnostic sensitivity than the skin prick. So the skin testing is two types, skin prick and intradermal. Out of that, intradermal is better. But it also has a higher risk of adverse reaction, because in skin prick we are only prick, they would only prick inside their skin, but in intradermal they would deposit the solution intradermally. So there would be a higher risk of adverse reaction. Intradermal tests with reading after 48 to 72 hours can be used to diagnose delayed, which is the T cell mediated hypersensitivity. These tests have lower sensitivity than for immediate reactions. You can try it for delayed tests as well, but these do not have good sensitivity for them. Uh, then skin tests for penicillin hypersensitivity should be performed by the specialist using both the penicillin major and minor determinants. These increase the sensitivity of testing. Then the second method of testing is in vitro testing, which is mainly the lab-based testing, where they will just put the antibiotic or the drug into the certain medium, and they would show how that would react to that. Okay, so in the context of immediate reaction, a significant elevation. So if there is any elevation of mast cell tryptase concentration enzyme detected in a blood sample collected 1 to 4 hours after a reaction may be helpful to identify mast cell degranulation. Other in vitro tests for IgE mediated hypersensitivity are available for benzyl penicillin, phenoxymethyl penicillin, amoxicillin, and cefaclor through commercial laboratories. However, such testing is of limited utility with concerns about false positive and false negative results. Okay, so they are not very good predictor. They can give false positive result. It means that the patient is not positive, but the result shows that he's positive. So it is known as false positive. Then the third type of testing is the drug provocation testing, which means that the drug, also called drug challenge, in which they prescribe the drug and they give the drug to the patient, and they would see how his body would respond to that drug. Is the controlled administration of a drug in order to diagnose the hypersensitivity. It is often used to confirm tolerance to an antimicrobial. Um, it is often used to confirm tolerance to an antimicrobial when skin prick or intradermal tests are negative or equivocal. Drug provocation testing should only be performed under medical supervision after consultation with an specialist in a safe environment where severe allergic reactions such as anaphylaxis. So, these reactions, if we are giving that drug to the patient, which we already know that he would be allergic to, then it should be done under the safe environment. If the reaction occur or if anything goes bad, we would be able to manage it, right? In carefully selected patients, example those with a history of benign rash in childhood or other delayed non-severe reaction, and with the specialist advice, direct oral challenge without prior skin prick testing can be considered when therapy with penoxim or okay. So these are Okay, so we will read in detail in the next pages, but I'm just letting you know, if the patient is allergic to penicillin, we can prescribe the clindamycin to him. Okay, it is a safe drug, we can prescribe him and it will act normally. But in certain cases, certain patient would only need the penicillin. So that's the cases where we need to perform these tests. These are not very normally done, but these tests needs to be performed to make sure that this patient is actually allergic to this drug. In patients with delayed non-severe hypersensitivity, prolonged oral provocation, like maybe if the patient has a history of delayed reaction, then they may need to give him the drug for 7 days. Following a supervised single dose provocation is often used to ensure the delayed hypersensitivity is not missed. Do not perform direct oral challenge without prior skin testing in patient with a history of severe. Okay, so if the patient has a history of severe allergic reaction, which is anaphylaxis, or which is either the DRESS or Steven Johnson syndrome, or AIN, or AJAP, or serum sickness, then do not prescribe. Then do not give any direct oral provocation without doing the skin prick test. Okay, so this drug they usually give to the patient who has non-severe, just a history like there was a rash when I took this drug, and very vague history. So this test is generally performed for those patients, but we do not really do that. They are done under the specialist settings. We just only refer them for the further management. The International Consensus on Drug Allergy provides detailed information about drug provocation testing. Alright, so we are done for the today pages, and hope you guys are getting benefit from these videos. And Alright, so I'll see you back with the next video. Thank you so much for watching.